Hello, my name is Andrew Stevenrock. I'm a radiology resident at the Ochsner Medical Center in New Orleans, Louisiana, and this is the May edition of the ACOR Cardiothoracic blog. Our first article is titled Prevalence of Abnormal Coronary Findings on Coronary Computed Tomography Angiography Among Young Adults Presenting with Chest Pain. This was from a recent Journal of Thoracic Imaging in March 2021. Group of researchers from NUSC, UT Houston, Advent Health, and Baptist Hospital, Miami sought to investigate the role of abnormal imaging findings on coronary angiography among patients aged 18 to 30 years old that presented with chest pain to the ED. Usually, when young people present to the emergency room with chest pain, they get a typical non-specific diagnosis, and that's usually due to a lack of risk factors. This study in particular examined atherosclerotic coronary artery disease, myocardial bridging, and anatomic coronary anomalies. 884 patients were included in the study if an angiography was performed for a chest complaint of chest pain between the ages of 18 to 30 years old. Exclusion criteria included known congenital heart disease, history of Kawasaki's disease, history of cardiac surgery, pregnancy, or if there was significant information missing from the medical chart. The angiograms were obtained using either Siemens or Philips Rose scanners. Coronary calcium scores were included within the studies as well, and the studies were all read by cardiac fellowship trained readers. Some of the parameters for atherosclerotic disease they characterized as stenosed or non-stenosed, and they graded the degree of any limital narrowing according to the CAD-RAD system, and if it was calcified or non-calcified. Coronary anomalies were characterized as potentially obstructive, including shunting, ischemia, or sudden cardiac death anomalies, or non-obstructive. The median ages for the patients were 27 for women and 28 for men. There's no evidence of hypertension among the data subset. They did see that the average BMI for these patients was considered obese. In women, the average was 34, and men, it was 31. Overall, 22.1% of the 884 scans were considered as abnormal. Coronary anomalies were more common in men than women, 25.2% to 17.4%. Myocardial bridging was the most common abnormality overall, present in 17.3% of patients. Atherosclerotic coronary artery disease was present in 4.4% of cases, and the coronary anomalies were present in 1.5% of cases. 1.1% of the cases had more than one abnormality, which was commonly seen more in men than women, and had a p-value of 0.05. 2.8% of the patients had a coronary artery stenosis on angiogram, and that was more commonly seen within the atherosclerotic disease patients rather than myocardial bridging. That was percentage-wise was 35.9% for atherosclerotic disease and 5.2% for myocardial bridging. Men were more likely to have stenosis than women, 4.1% of patients that were men compared to 1.1% of patients that were women. The left anterior descending artery was most commonly affected, with 19 total patients, followed by the right coronary artery with 2 patients, and the left circumflex coronary artery with 1 patient. Most patients that had a degree of stenosis were minimal or mild. Of note, 4 patients did have moderate stenosis, and 3 patients were considered severe stenosis. Of the risk factors for atherosclerotic disease, age was significantly associated. There wasn't any atherosclerotic disease seen in patients at 27 or below, but it did seem to be present age 29 and 30. Overall, given lower prevalence of pathology in younger patients presenting with chest pain, discretion should be utilized prior to performing any ionizing radiation studies. However, clinical medicine is art and science, and in patients with significant cardiovascular risk factors, the risk of radiation should not be a limiting factor. Some of the limitations for this study include the fact that it was retrospective in nature. The researchers weren't able to calculate heart or TIMI scores due to incomplete documentation in the medical record, and there's likely higher than normal prevalence of coronary anomalies due to presenting chest pain symptomology. Our next study is titled Real-World Lung Cancer CT Screening Performance, Smoking Behavior, and Adherence to Recommendations. Lung RADS category and smoking status predict adherence. This is from the American Journal of Radiology, volume 216. Researchers from the University of Pennsylvania sought to investigate the role of low-dose CT lung cancer screening performance and factors predictive of adherence to lung cancer screening recommendations. The U.S. National Lung Screening Trial and Dutch-Belgian Lung Cancer Screening Trial both have shown significant reduction in mortality with lung cancer screening patients. This particular article was a 5-year retrospective study where patients who underwent multiple low-dose screening scans were included. Exclusion criteria included treatment for any cancer other than non-melanoma skin cancers or carcinoma in situ within the past 5 years, or if there is any diagnostic just CT in the past 12 months. Images were not directly reviewed, and evaluation relied completely on dictated reports in the medical record. Imaging protocols varied, but the effective dose for all studies was 1.5 millisieverts. Using the dictated reports and the EMR, patients were classified via the Lung RADS version 1.0 categories. To review those, category 1, no suspicious findings. 2, nodules with extremely low risk of malignancy. Those were considered negative examinations in this study, and positive screening examinations were included in categories 3, 4A, 4B, and 4X. Initially, 1,334 patients were evaluated for the study, and after the exclusion criteria were applied, there were a total of 260 patients included. Outside of imaging findings, patient demographics, smoking history, incidental findings, outcomes such as cancer diagnosis or changes in smoking behavior, and adherence to screening recommendations were included in the analysis. Performance metrics for the program included sensitivity, specificity, positive predictive value, and negative predictive value. And they determined adherence to screening recommendations to be an exam performed within 1 month of the expected data follow-up, or within 3 months if PET CT or biopsy was recommended. For the results, 117 of the 260 patients were former smokers, 143 patients were current smokers, with 114 continuing to smoke over the course of the study. 29 patients quit before the last round of low-dose screening exams. 7 patients were former smokers who had started again after the baseline study and before the last recorded low-dose CT. So, in conclusion, as far as patient demographics go, after the final round of low-dose CT scans, the current smoking group included 121 patients and the former included 139 patients. Wide variability within lung nodules ranging from 0 to 50 total quantity, and varying size ranging from 0 to 22 millimeters. Solid nodules were the most common at 62% when nodules were present on scans. The remaining subtypes, such as no nodules, was 33% of the patients. Ground glass nodules were seen in 4% of the patients, and subsolid nodules seen in 1% of the patients. Right upper lobe nodules were the most common lobar preference at 23%. Positive screening exams, which, just to rehash, was category 3, 4A, 4B, and 4X, were found in 16.5% of patients, or 43 total patients. Primary lung cancer was diagnosed in 3 of the 260 patients. All cancers were detected in the second round of screening. Mean follow-up length for negative scans was 884 days with an adherence rate of 43%. After a statistical analysis was performed, the 2 factors that increased adherence was lung RADS category and smoking status. Adherence rate increased progressively depending on the lung RADS criteria if it was higher with a p-value of 0.001. For example, if they had a category 4 exam compared to a category 3 exam, they're more likely to follow up at the expected interval. And additionally, positive screening exams had a higher adherence rate than negative exams. 65.1% of patients with a positive initial screening exam showed up for the the next expected exam versus 41.2% in the negative exams. Adherence rate was also increased from former smokers compared to current smokers. 50.0% of patients that were former smokers adhered to the expected follow-up date compared to 36.2% within the current smokers group. The rate of positive examinations was 16.5%, like discussed previously, and that was higher than expected compared to the lung RADS expectation, which is 9%. However, most of the positive exams were confirmed as not lung cancers, as there was only 3 total in this group. The study showed high sensitivity and negative predictive value, but moderate specificity and very low positive predictive value. Ultimately, this study shows important demographics who should be targeted to ensure follow-up. However, there are limitations, as there are with every study. This is a single-center study, and populations in Philadelphia may not be extrapolated across the U.S. and the world. Additionally, cultural and socioeconomic factors always play an important role in these studies, which can be skewed by a study taking place in a northeast U.S. city. I think a multifactorial approach between radiologists and primary physicians should be encouraged to increase education among patients that low-dose screening exams are important for mitigating future risk of lung cancer development. Our third article is titled Frequency and Reliability of the Reversed Halo Sign in Patients with Septic Pulmonary Embolism Due to IV Substance Use Disorder. This is an article from the American Journal of Rheumatology in 2020, volume 214. Researchers from Harvard University and Federal University of Rio de Janeiro sought to investigate the utility of the reverse halo sign in patients with septic pulmonary emboli due to intravenous drug use. The reverse halo sign is defined as a focal rounded area of central ground glass opacity surrounded by a focal ring of consolidation. This sign has been associated with multiple infectious and non-infectious etiologies such as organizing pneumonia, tuberculosis, fungal infections. The morphology of the halo can be important to help differentiate between infectious versus non-infectious etiologies as described in previous literature. And in regards to emboli, the reverse halo sign is also used to refer to pulmonary infarct because of the emboli. This is a retrospective study that reviewed 15,000 plus examinations through a radiology database with multiple different search criteria. They found 78 chest CTs from 64 patients that associated drug abuse and septic emboli. After reviewing the medical record of these patients to find acceptable documentation regarding IV drug use, positive blood cultures, or responsive pulmonary findings to an antibiotic regimen, these patients were included within the study cohort. Studies were performed on both GE and Siemens scanners. Approximately 60% of the scans were done with iodinated contrast, and they included both inpatient and follow-up outpatient examinations. Studies were reviewed by thoracic trained radiologists. Each study was assessed for the reverse halo sign and considered present if 2 radiologists agreed that it was present in at least one study for the patient. The reverse halo sign frequency, contour, shape, location, and presence of central reticulations or low attenuation areas were assessed, as well as evolutional changes on follow-up examinations. The final cohort included 62 patients who underwent a total of 203 examinations. The average number of chest CTs per patient was 3.3. All patients underwent echocardiography, and 63% were found to have valve vegetations. 92% had positive blood cultures, and lung nodules were found in 100% of scans. Other findings that were noted on the CT scans within the lungs, 92% of patients had cavitations and 79% had pleural effusions. Reverse halo sign was seen in 59.7% of patients with a mean of 2.1 with a standard differentiation of 1.7. 46.7% of patients had more than one sign. Most halo signs were seen in the periphery without a lobar or shape preference. Central hypoattenuation was more common than central reticulations. Percentages for that was 65.4% central hypoattenuation versus 34.6% central reticulations. On follow-up scans, the halo sign was characterized for evolution, showing cavitation in 37.2% of the time and consolidation 30.8% of the time. 13% of the time, the halo was seen to decrease in size without development of consolidation or cavitation. And resolution was seen in 63% of patients at an average time frame of 85 days with a standard deviation of 46 days after the initial scan positive for the sign. Overall, the reverse halo sign was shown to be associated with septic emboli from IV drug use, with more than half of the patients within the cohort having imaging findings. This study suggests that the reverse halo sign is related to the healing process of pulmonary infarcts caused by septic pulmonary embolism. This study did have a small sample size, which is a limitation. However, the prior articles have shown that septic PE is associated with the reverse halo sign more often than traditional pulmonary embolism. Initial results from the study are interesting, and more research could be helpful in determining if this would be a good imaging biomarker for differentiating septic pulmonary embolism from other causes of pulmonary embolism. Some other additional limitations for this study is likely underreporting of patients with suspected IV drug use and selection of patients with more severe manifestations which required imaging studies for clinical management. Our final article is titled, Can Chest CT Features Distinguish Patients with Negative from Those with Positive Initial PCR Results for Coronavirus Disease? This was from the American Journal of Retinology, issue 216 in January 2021. Researchers from Guangzhou First People's Hospital in China investigated if there are any features on chest CT that can help distinguish patients that may have an initial false negative PCR from patients that are initially positive. And PCR tests are not perfect, and a variety of reasons can lead to false negatives, such as reagent issues, technique, or inadequate specimens. And especially early on in the pandemic, before we were 100% sure that the test was picking up every case. Chest CT was found to be useful early within the pandemic to be more sensitive for detection of findings that would raise concern for COVID-19 in the incubation period prior to the virus being detectable via PCR as well. This study was retrospective, and 21 patients were identified between January and February 2020 who had initially been tested for COVID-19 via PCR. 7 of the patients had initial negative PCR results and then tested positive 2 days later. There's a total of 21 patients included. Chest CT was performed supine with maximum inspiration using a variety of scanners, including Siemens, GE, and Philips. The studies were reviewed by thoracic trained radiologists blinded to clinical data, and consensus was reached by the 2 radiologists. If there was a disagreement between the 2 radiologists, a third radiologist was brought in to the case for the final decision. Multiple imaging characteristics were evaluated, including distribution of the findings, the attenuation, presence of air bronchograms, vascular enlargement, interlobular septal thickening, lymphadenopathy, pleural effusions, and pulmonary fibrosis. Of the 21 patients, 9 were men and 12 were women, ranging from 26 to 90 years old, with an average age of 49.7 years. 90% of the patients had had exposure to a person with COVID-19 or had recently been to the Wuhan area of China. As far as imaging findings seen on these patients, CT showed that the wide majority had bilateral findings, and then isolated left or right lung were seen 14% of the time. Most of the time, multiple lobes were involved, approximately 67% of the time, and the other 33% were isolated into one lobe, more predominantly within a lower lobe. Ground glass opacities were seen in 95% of the patients, and 71% of patients had consolidation. 100% of the lesions were seen subpleural, with 33% of patients additionally showing findings along the bronchovascular bundle. Air bronchograms were present in 57% of patients, vascular enlargement in 67% of patients, and interlobular septal thickening in 62% of patients. Pleural effusions were only seen in 19% of patients. When comparing the 7 patients initially PCR negative to the 14 that were initially positive, consolidated findings were seen more prominently within the positive patients with a p-value of 0.04. Otherwise, there's no significant differences between the 2 groups. Overall, the study has several limitations. It is a retrospective study with a small case number. Further evaluation with a larger sample size can produce different results. It was beneficial that patients were seen at multiple centers throughout the Guangzhou region. However, at the same time, it is still a single province in China, and these findings might not necessarily be representative across the world. Another limitation is PCR methodology. This testing method could be affected by technique, reagents, inadequate specimens, and negative exams could have a variety of reasons besides viral load as to why it was initially negative. Thank you for taking the time to listen to this presentation, and we look forward to seeing you back in 2 months for the next edition of the Cardiothoracic blog for ACOR. Thank you.